welcome back to the deep dive. There's a specific phrase in the medical text we're looking at today that it really just stopped me in my tracks.
Yeah.
It described the onset of the condition we're covering as insidious.
It's a heavy word, isn't it? Insidious.
Yeah,
It implies something treacherous almost, something sneaking up on you while you're looking the other way.
exactly. It makes you realize that what we think we know about Parkinson's disease, the shaking hand, the elderly relative moving slowly, that's really just the final act. The end of a play that's been running silently in the brain for years, maybe even decades.
That is the perfect way to frame this deep dive. Today, we are unpacking Chapter 56, Parkinson's disease, from a comprehensive medical text. And our mission really is to rewind that tape.
Right.
We want to understand the biological machinery that breaks down long before anyone even notices a tremor. We need to look at the pharmacology, which is, frankly, a high-stakes chess game played with brain chemistry.
And it really is a chess game. I was just blown away by the section on treatment. It's not just take a pill and call me in the morning.
Not even close.
It's this delicate balancing act. It involves, blood-brain barriers and protein interference from your lunch, of all things.
Yeah.
And side effects that can be wildly different from the disease itself, like I was reading about gambling addictions or hallucinations.
It's one of the most complex chapters in neurology, truly. We're dealing with neurochemistry, patient psychology, and a timeline that can span 20, 30 years.
Wow.
So if you're ready to understand the why and the how of Parkinson's, we have a lot to cover.
Let's jump right into the machine then, or maybe the broken part of the machine. The source material gets very specific about where this all starts. It points a finger at a very tiny, specifically named part of the brain.
The substantia nigra pars compacta.
Which sounds like a spell from Harry Potter.
It does a bit.
But it's actually anatomy. And the name, it literally translates to black substance, right?
That's right. Latin for black substance. In a healthy brain, if you were to, say, look at a cross-section of the midbrain, you'd see this distinct dark streak.
Okay.
That pigmentation is actually neuromelanin, which is a byproduct of dopamine production.
So in a healthy person, it's dark because it's a busy factory just churning out dopamine.
Exactly. But in a Parkinson's patient, that strip, it fades, it loses its color, it turns pale because those specific neurons are dying off.
And is that where Lewy bodies come in? I saw that term.
Yes. The hallmark feature of this cellular death is the presence of these microscopic protein clumps called Lewy bodies inside the remaining neurons. They're essentially the tombstones of the cells.
Okay, let's unpack dopamine.
Yeah.
Because in pop culture, we hear dopamine and we think happiness or reward.
Right.
We think about scrolling on social media or eating chocolate or winning a bet. But here, we're talking about movement. What's the connection?
That's a crucial distinction. Dopamine is a multitasker. Yes, in the mesolimbic pathway, it's all about reward and desire. But we're looking at the nigrostriatal pathway. Okay. And here, dopamine is purely functional. It acts as the oil in the engine of movement. It facilitates smooth, controlled muscle activity.
So when that oil runs dry, the gears just grind to a halt.
In a sense, yes. But to be more precise, it's about the balance between go and stop. The text explains it through receptors dopamine 1 and dopamine 2. Think of your motor system like a car. The brain is constantly sort of keeping the brake pedal pressed down so you don't just flail around uncontrollably.
Right, that makes sense.
So to move, you need to lift the brake and hit the gas.
And dopamine is the foot that hits the gas.
Essentially, dopamine stimulates the D1 receptors, which is the direct pathway, that's the gas, and it inhibits the D2 receptors, which is the indirect pathway, that's the brake.
So when you lose that dopamine...
When you lose that dopamine input from the substantia nigra, you lose the ability to press the gas and the brakes get slammed down hard.
And the downstream effect of slamming on the brakes is that the thalamus gets shut down.
Correct. The thalamus is the relay station in the brain. It acts like a gatekeeper. It wants to send a go signal to the motor cortex to move your arm.
But the internal wiring is saying no.
The internal circuitry says no. So the thalamus gets inhibited. It goes quiet.
And because the thalamus is quiet, it sends less activation to the motor cortex.
Which means the motor cortex can't tell the muscles to move. The result is a body that wants to move. The will is there, but the signal just dies on the vine.
Okay, here is where it gets really interesting and honestly a little bit terrifying. The source mentions a threshold. We talked about the disease being insidious. The text says the patient remains asymptomatic. They feel fine. They look fine. until a huge percentage of those neurons are already dead. What was that number again?
70 to 80%.
70 to 80. That just blows my mind. You lose 80% of your dopamine-producing neurons before you even notice a little tremor.
It speaks to the incredible plasticity and redundancy of the human brain. It fights to stay normal. It compensates. It ramps up dopamine production in the remaining cells, or it makes the receptors more sensitive. It masks the problem for years.
So the thief has been in the house for a long time before you realize the jewelry's gone.
Precisely. By the time a patient walks into a doctor's office saying, "Doc, my thumb is twitching," the biological damage is already profound.
Wow.
That 70 to 80% depletion has already occurred. The war has been raging in silence, and the patient only notices it when the brain finally runs out of ammunition.
That context just changes everything. So when we see the symptoms, we're really looking at the aftermath of a very long battle.
Exactly.
Let's talk about those symptoms. We're moving from pathophysiology to the clinical presentation.
The physical manifestation of the disease.
Right. And again, we have to talk about the classic image versus the reality. If you ask someone to mime Parkinson's, they'll shake their hand. They'll do the tremor.
The resting tremor.
But the text says that's not always the case.
It's a common misconception. The source notes that resting tremor is often the sole presenting complaint, yes. But, and this is critical, only about 2/3 of patients have a tremor upon diagnosis.
So 1 out of 3 people doesn't.
1 out of every 3 people diagnosed with Parkinson's does not have a tremor at that stage, and some never develop it at all.
So you could have Parkinson's and be completely still.
You could. Which is why understanding the full spectrum of symptoms is so important. We can't just rely on the shake.
But let's look at that tremor for a second, because for those who do have it, it has very specific characteristics. It's not just a generic shakiness. The text describes it as pill rolling.
Which is such an evocative old-school medical term.
It really is.
It comes from the days when apothecaries used to manually roll pills into round shapes. It describes this rhythmic motion of the thumb and forefinger rubbing together.
And crucially, the text emphasizes that it is a resting tremor.
That is the key differentiator. It happens when the hand is just sitting in the lap, fully supported against gravity. The text points out that it's usually abolished by a volitional movement.
Meaning if you try to do something, it stops.
If that patient reaches out to grab a cup of coffee, the shaking often stops, or at least diminishes significantly.
That's a huge difference from, say, essential tremor, where the shaking gets worse when you try to do something.
Correct. Essential tremor is an action tremor. Parkinson's is a resting tremor. Also, the Parkinson's tremor typically starts unilaterally.
Just on one side.
Just one side. A patient might notice their left hand shaking while they're watching TV, but their right hand is perfectly steady. And interestingly, it's completely absent during sleep.
Okay, so if the tremor isn't always there, or if it disappears when you move, what are the other primary features, the big 4, so to speak?
We group them as tremor, rigidity, bradykinesia, and postural instability, TRAP.
Let's break those down. Rigidity. This isn't just feeling sore from the gym.
No, this is an increased resistance to passive movement. If a doctor tries to move the patient's arm for them, bending the elbow back and forth, it feels stiff. But it has a specific quality called cogwheel rigidity.
Like a ratchet. Click, click, click.
Yes, exactly. It's not a smooth stiffness like a lead pipe. It has this jerky, ratcheting quality. It's essentially the tremor superimposed on the increased muscle tone.
Then you have bradykinesia, which translates literally to slow movement.
But slow just doesn't quite capture the tragedy of it. It's often the most disabling symptom. It's a poverty of movement. It's a difficulty in initiating movement.
So like getting started.
Getting started and all the automatic things you do without thinking, swinging your arms when you walk, blinking your eyes, they stop.
Is that why patients develop what the text calls masked faces, the mask-like face?
Yes. Reduced facial expression. It can be heartbreaking for the patient and their family because it affects communication so much. The person might feel happy or sad or engaged, but their face looks flat, uninvolved.
They aren't bored.
No, they're not bored. Their facial muscles just aren't receiving the signal to emote.
And then postural instability. That's balance issues, leading to falls.
Which usually happens later in the disease course, but it is a major cause of injury and hospitalization.
But those are just the things you might see on the surface. The source lists a whole iceberg of other symptoms that define the daily struggle, the stuff that's maybe not as obvious.
These are the non-motor symptoms, and often these can appear years, even a decade before the tremor.
Really? Like what?
The text mentions things like hypophonia, a very soft, breathy voice, micrographia handwriting that gets smaller and smaller as they write across the page.
I found the list of autonomic issues really tough, too. Difficulty swallowing, constipation, bladder disturbances, sleep apnea. It's a systemic breakdown. It's not just my handshakes.
Not at all. And that is why the diagnosis requires such a keen eye. There is no blood test for Parkinson's. There's no MRI that lights up and says, yes, this is it in the early stages.
So how do they confirm it? How do you know for sure?
It's a clinical diagnosis. The text outlines that to diagnose Parkinson's with a high level of confidence, you need the bradykinesia, the slowness, plus at least one of the others, so tremor or rigidity.
Okay.
And, very importantly, you need to see a positive response to dopaminergic medication.
That's interesting. So the test for the disease is, in part, does the drug work?
In many ways, yes. We call it a challenge test. If you give them L-Dopa and they don't get better, you have to step back and question if it's actually Parkinson's.
Because something else could be causing it.
Absolutely. The text explicitly lists things you have to rule out, like drug-induced Parkinsonism.
Right, I was surprised by that.
Yeah.
Certain drugs can mimic Parkinson's.
Oh, for sure. Traditional antipsychotics or even some common anti-nausea drugs like metoclopramide. These drugs work by blocking dopamine receptors. So if you block the receptors, you are chemically recreating the exact same brakes-on situation as Parkinson's disease.
So you don't want to treat a side effect with another heavy drug. You want to stop the offending agent.
Exactly. You have to play detective.
Speaking of heavy drugs, let's transition to the treatment. We've established the problem. The substantia nigra has shut down, and we're low on dopamine. The logical thought process, the host-speaker logic, would be, okay, we're low on dopamine. Here's a glass of dopamine. Drink it up.
A very logical thought, but physiologically impossible.
Why?
Because of the blood-brain barrier. Think of the brain as a VIP club. It has a velvet rope, the blood-brain barrier that surrounds it, keeping toxins, bacteria, and foreign substances out of that sensitive brain tissue.
Okay.
Unfortunately, it also keeps dopamine out. Plain dopamine is structurally unable to cross that barrier. It can't get past the bouncer.
So if you inject dopamine into the blood, it just stays in the body.
It stays in the periphery, the body outside the brain. And since there are dopamine receptors in your heart and your gut, injecting dopamine just causes massive nausea, vomiting, and cardiac arrhythmias. It makes you sick, but it does nothing for the movement disorder because it never gets into the club.
So medicine had to find a Trojan horse.
Enter L-Dopa, Levodopa. It is a precursor to dopamine, a chemical building block. L-Dopa does have a ticket to get into the club. It can cross the blood-brain barrier.
Okay, so it gets inside.
Once it gets inside the brain, an enzyme called amino acid decarboxylase, let's just call it the converter enzyme, converts it into dopamine.
Problem solved.
Not quite, because that converter enzyme, it's not just in the brain, it's all over your body. It's in your gut, your liver, your blood.
Ah. So you take the L-Dopa pill, it goes into your stomach, and the enzyme in your body converts it to dopamine before it ever gets a chance to reach the brain.
Exactly. And then you are right back to square one. Peripheral dopamine causing nausea and heart issues, and very little L-Dopa actually making it to the brain to do its job.
So we need a bodyguard.
That is the perfect analogy. And that bodyguard is a drug called carbidopa.
I love this mechanism. Explain how carbidopa saves the day.
Carbidopa is an inhibitor of that converter enzyme. But here's the brilliant trick. Carbidopa cannot cross the blood-brain barrier.
So it only works in the body.
Yes. It blocks the conversion of L-Dopa into dopamine in the body. It essentially sacrifices itself to distract the enzyme in the periphery.
Wow.
This allows the L-Dopa to travel safely through the blood and cross the barrier into the brain. The carbidopa stays behind. Once the L-Dopa is in the brain where the carbidopa can't reach it, the brain's enzymes are free to convert it to dopamine right where it's needed.
That is incredibly elegant. It protects the drug where you don't want it to work and lets it work where you do.
It is the gold standard. That combination, carbidopa-levodopa, you'll hear it called Sinemet, is the absolute cornerstone of therapy. The text notes that ultimately, virtually all PD patients will require L-Dopa.
But even with this gold standard, there are nuances. I was reading about protein interference. The source says high-protein meals can mess everything up. How?
This comes down to how L-Dopa is absorbed. It isn't just passively absorbed. It has to ride a specific transport system in the small intestine to get into the blood. Think of it like a bus with limited seats.
Okay.
And the problem is dietary proteins, amino acids use the exact same bus.
It's a traffic jam.
It's competition. If you eat a big steak dinner and take your medication at the same time, the amino acids from the steak might fill up all the seats on the bus. The L-Dopa gets left behind in the gut, breaks down, and never gets absorbed properly.
So patients really have to time their meals and their meds.
Education is key here. We often tell patients to take the medication maybe 30 minutes before a meal or to save their high-protein meals for the evening when mobility might be less critical. It's all about customizing the delivery.
This idea of customizing brings us to what I was thinking of as the strategy of time. Because Parkinson's isn't a condition you treat for a week like an infection. You're treating it for 10, 20, 30 years.
And that timeline dictates the entire strategy. The text makes it very clear. The goal is to minimize symptoms and side effects while maintaining quality of life. But the approach changes drastically depending on the patient's age.
Right. There's a specific algorithm in the source figure 56.1 that splits patients into two groups, under 65 and over 65. Why is 65 the magic number?
It's a guideline, of course, not a hard rule, but it's about balancing two major risks. On one side, you have motor complications. On the other, you have psychiatric side effects.
Let's unpack the under 65 group first. Why would doctors hesitate to start L-Dopa immediately if it's the gold standard?
Because L-Dopa has a kind of a shelf life of efficacy. Not that the drug itself stops working, but that the brain starts to react badly to it over time.
How so?
The longer you're on L-Dopa, especially at higher doses, the more likely you are to develop those jerky, uncontrolled movements called dyskinesias.
Okay.
So if you start a 50-year-old on high-dose L-Dopa, by the time they're 60, they might be severely disabled by the medication itself.
So for the younger folks, you want to save the heavy artillery for later. You want to spare the L-Dopa, as they say.
Exactly. So for the younger group, the algorithm often suggests starting with a different class of drugs, the dopamine agonists.
The mimics.
Right. Unlike L-Dopa, which gets converted into real dopamine, agonists just pretend to be dopamine. They bind directly to the dopamine receptors and trick them into firing.
Drugs like pramipexole, ropinirole, rodigatine.
Yes, they're effective, and they have a much lower risk of causing those long-term motor complications and dyskinesias.
But.
Yeah.
And there is always a but in this chapter.
The side effects. This is the vice section I mentioned in the intro. I was reading the side effect table, and it is just wild. We are not just talking about dry mouth here.
No, we're not. It's a fascinating and sometimes devastating side effect profile. Because these drugs stimulate dopamine receptors, and remember, dopamine is the currency of the reward pathway, they can trigger compulsive behaviors.
The source explicitly lists gambling, compulsive shopping, and hypersexuality.
We have seen cases where a mild-mannered accountant starts staying out all night at casinos, or a grandmother fills her garage with compulsive purchases from the home shopping network. It can be life-altering.
Yeah, and the scary part is they often don't feel out of control. It's not like they're fighting it. That's right. They just feel a very strong, undeniable urge. It rewires the reward system. And the text also mentions sleep attacks, suddenly falling asleep without warning, even while driving or eating.
So if you are younger, you roll the dice with the agonists to avoid the shaking later. But if you are over 65...
If you're over 65, the calculation flips. Older brains are more fragile. They are much more prone to the psychiatric side effects of the agonists, hallucinations, confusion, and also orthostatic hypotension, which is passing out when you stand up.
So a bigger fall risk.
A much bigger fall risk. L-Dopa is generally much better tolerated in the elderly regarding these mental side effects. So for the over 65 group, we often go straight to the gold standard, L-Dopa. We prioritize immediate quality of life and safety over that long-term risk of dyskinesia.
It's such a delicate trade-off. Now, besides the agonists and L-Dopa, the source lists a bunch of adjunct therapies. I was thinking of these as the clock extenders.
That's a great way to put it.
They seem designed to make the L-Dopa last longer in the system.
That is their primary role. As the disease progresses, a single dose of L-Dopa just doesn't last as long. So we use these helpers. Let's look at the MAO-B inhibitors first. Selegiline and rasagiline.
MAO-B, monoamine oxidase B.
Correct. MAO-B is another enzyme in the brain that breaks down dopamine. Think of it as the janitor that sweeps up the dopamine after it's been used.
Okay.
If you inhibit the janitor, if you stop the breakdown, the dopamine stays in the synapse longer and can work harder.
Now, I've heard of MAO inhibitors in the context of depression, and usually there's a big warning about cheese, the cheese reaction.
Yes, the infamous tyramine reaction.
Okay.
In older, non-selective MAO inhibitors used for depression, eating aged cheese or drinking red wine could cause a massive, dangerous spike in blood pressure.
Right.
However, the text clarifies that for selegiline and osagiline, at the doses we use for Parkinson's, this cheese reaction is very unlikely. They are selective for MAO-B.
So you can have your Gouda and eat it too.
Within reason. But there is a weird tidbit about selegiline metabolites that the text points out. It says selegiline breaks down into L-methamphetamine and L-amphetamine.
Wait, methamphetamine?
Right.
Like meth?
Yes. Chemically, it's a form of amphetamine, which explains why a very common side effect is insomnia. If you take selegiline right before bed, the metabolites act like a stimulant and can keep you awake all night.
Okay, noted. Don't take selegiline at bedtime. What about the other class of extenders, the COMT inhibitors, entacapone and tolcapone?
These work in the periphery, similar to how carbidopa works, but on a different enzyme. They block something called catechol-O-methyltransferase. Basically, they extend the half-life of L-dopa in the blood. They just keep the fuel in the tank for longer.
But there are some visually distinct side effects here. Entacapone turns your urine brownish-orange.
It does. It's totally harmless. But imagine if a doctor forgets to warn the patient. You start a new drug, and suddenly your urine looks like neon rust. It can be terrifying.
And tolcapone, that one sounded more serious.
Tolcapone is the dangerous cousin. The text states its use is extremely limited because of fatal liver toxicity.
Wow.
It requires strict, regular monitoring of liver function. It's a break glass in case of emergency drug. We only use it when nothing else works.
Then there is amantadine. This one is weird because it started as an antiviral, right, for the flu.
Serendipity at its finest. It was originally used for influenza A. Then doctors noticed that Parkinson's patients who took it for the flu suddenly had less tremor and rigidity.
And they figured it out from there.
Yep. We still aren't 100% sure of the exact mechanism. It likely has to do with blocking glutamate, but it's now used specifically for tremor and, importantly, for L-dopa-induced dyskinesia.
And it has a side effect with a very fancy name, levodoreticularis.
It describes a skin reaction, a diffuse modeling of the skin, usually on the legs. It looks like a purple lacy net under the skin.
It sounds like a spell, looks like a net, but it's reversible if you stop the drug.
Correct.
Okay, finally in this grab bag we have anticholinergics, things like benztropine.
These are old drugs. They're pretty good for tremors, but they are messy drugs. They block acetylcholine. The text warns that they're really risky for the elderly because they cause confusion, memory loss, and urinary retention. In a disease that already risks dementia, you want to be very, very careful with these.
So we have the toolkit. We have the L-dopa, the bodyguards, the mimics, and the extenders. But the disease doesn't stand still. It progresses. And this brings us to Section 6, managing the roller coaster, the motor complications.
This is the heartbreak of the long-term treatment. After a few years, what we call the honeymoon period, the brain loses its ability to buffer the dopamine. It becomes completely dependent on the exact level of drug in the blood at any given moment.
And since pills provide a spike and then a drop, the patient's movement starts to spike and drop with it.
Exactly. We see the wearing off phenomenon. The patient takes a pill at 8 a.m., expects it to last until noon, but by 11 a.m., the tremor comes roaring back. The off time creeps in earlier and earlier.
So what do? Take more pills?
You can increase the frequency, take them every 3 hours instead of 4, or you add those extenders we talked about, the COMT or MAO-B inhibitors, to bridge the gap, but then you can run into the opposite problem.
Peak dose dyskinesia.
Right.
This is what most people identify with Michael J. Fox in his later years.
Yeah.
All that extra writhing movement.
Yes, coriform movements. They're dance-like, twisting, involuntary movements. This happens when the dopamine levels peak in the brain, maybe an hour after taking the pill. The receptors just get overstimulated.
So it's a total paradox.
Yeah.
If you give enough drug to stop the stiffness and freezing of Parkinson's,
You cause the twisting and writhing of dyskinesia.
and if you lower the dose to stop the twisting, the patient freezes up again.
That is the dreaded on-off switch. The patient can fluctuate wildly, sometimes within minutes, between being mobile but dyskinetic, what we call on, and being frozen and rigid or off. It becomes a very, very tight therapeutic window to hit.
The text mentions freezing specifically as a start hesitation, like your feet are just glued to the floor.
It's a terrifying sensation for patients. They want to walk, their brain is screaming, walk, but their feet will not lift. It often happens in doorways or when turning around.
Interestingly, the text suggests sensory cues can help.
Yeah.
Stepping over objects. What is that about?
This is one of the most amazing hacks in all of neurology. A patient can be completely frozen, unable to take a single step on a blank floor. But if you put a line of tape on the floor and say, step over the tape, they can do it easily.
How is that even possible?
It's because stepping over something uses a different pathway in the brain. It engages the visual cortex, and it bypasses the broken basal ganglia loop. It's like taking a known detour around a massive traffic jam.
That is mind-blowing. It really shows how modular the brain is.
It's incredible.
But when the freezing is severe or the off period is sudden and debilitating, there's a rescue option mentioned in the source, apomorphine.
This is the heavy artillery for rescue. It's a very potent dopamine agonist. It's a subcutaneous injection, like an EpiPen.
So if you are stuck in a chair and literally cannot move, you inject this.
Someone injects it for you, usually. And it works in about 20 minutes to trigger an on state. It can be a lifesaver for people who get sudden, profound off periods, but it causes severe nausea, so you have to pre-medicate with anti-nausea drugs.
It really emphasizes how high maintenance and all-consuming this condition becomes. And we haven't even talked about the darkest side of the treatment yet. Section 7 deals with psychosis and hallucinations.
This is often the breaking point for caregivers. The text notes that the cause is almost always drug-induced. The very drugs giving them mobility, that dopaminergic excess, can cause them to see things that aren't there.
The mesolimbic pathway again.
Yes. By treating the motor pathway, we accidentally overstimulate the psychosis pathway. Patients might see animals or children or shadowy figures in the corner of the room.
So how does a doctor handle this? You need the drugs to move, but the drugs are making you hallucinate.
The source outlines a very logical, stepwise approach in Table 56-4. It's essentially a subtraction game. You start stopping the drugs in the order of least necessity or highest risk for causing psychosis.
Walk us through that order. What goes first?
First, you cut the anticholinergics. They are the worst for the mind and usually offer the least benefit for mobility. Then, you taper off amantadine. Then the MAO-B inhibitors. Then, the dopamine agonists.
Wow. So you strip almost everything away until you are just left with L-Dopa.
Essentially, yes. You reduce the L-Dopa last because it is the most essential for basic movement. But if you have stripped everything away and the patient is still hallucinating, you have to turn to antipsychotics.
But wait, didn't we say earlier that antipsychotics can cause Parkinsonism? That seems like a terrible idea.
Traditional ones, yes. They block dopamine and would make the patient rigid as a board. But the text recommends atypical antipsychotics, specifically quetiapine or clozapine. These affect dopamine differently or bind more loosely, so they can treat the psychosis without making the movement disorder drastically worse.
There's a big caveat on clozapine, though.
A very big one. It requires frequent, intensive monitoring for something called leukopenia, a dangerous drop in white blood cells that can lead to fatal infections. So the patient needs weekly blood tests, at least at first.
My gosh.
It's a logistical nightmare, but for a patient who is tormented by hallucinations, it can be a miracle drug.
It seems like every door you open in this disease has a warning sign on the other side.
That is a very fair assessment. It's a condition of constant trade-offs.
So what does this all mean? We've gone from the microscopic death of neurons in the substantia nigra to the pill-rolling tremor, the strategies of timing your meals, the gambling side effects, and the hallucinations.
I think the summary here is really about appreciating the complexity. Parkinson's is not a static condition. It is a journey. It starts with that 70 to 80% neuron loss threshold, moves through a honeymoon period of treatment, and then evolves into this incredibly complex cocktail of medications where every milligram counts.
And the big takeaway for me is that while L-Dopa is inevitable for almost everyone, the art of it is in the delay. It's in using the mimics and the bodyguards and the extenders to keep the quality of life high for as long as possible before those complications set in.
Exactly. It highlights that the art of medicine is just as important as the science. It's about knowing when to introduce a therapy, not just what therapy to use. It's about treating the person, not just the tremor.
I want to leave the listener with a thought that really stuck with me while reading this. We talked about the iceberg of symptoms. When you see someone with Parkinson's in the grocery store, maybe you see the tremor. Maybe you notice they look a little stiff.
But that is just the visible peak, the 10% above the water.
Right. Under the surface, they might be battling the wearing off anxiety, wondering if they can finish their shopping before their meds crash. They might be using those sensory tricks we talked about just to lift their foot over a crack in the tile.
Mm-hmm.
They might be fighting the urge to gamble caused by their agonists, or dealing with the vivid dreams and hallucinations we discussed.
It is a profound battle that happens largely invisibly.
So the next time you see that tremor, remember the chess game that is happening behind the scenes. It just gives you a whole new respect for the patients and the neurologists who are managing this tightrope walk every single day.
Well said. Knowledge is empathy.
Thanks for diving deep with us today. We'll see you on the next one.